My name is Dr. Thomas Newton. I am the Department Chair for Pediatrics here at Walter Reed, and I will be your MC this morning. Colonel Heimel.
Well, welcome everybody. This is really a continuing endeavor in Walter Reed National Military Medical Center's legacy to discovery and to teaching, education, and research, and phenomenal care for our patients and their families when they're with us. Whenever we do something like this, it is absolutely, I think, important for us to have the patient and the family perspective as we go through. Because what we are in the business of doing is curing disease and improving quality of life. I think back to my early days when I served at Walter Reed Army Medical Center on Georgia Avenue, and Dean Kellerman down at the Uniformed Services University, the dean of the medical school, is fond of saying that in the old days, and for those of us who are over 50, we remember the old days of education, research, and patient care. But back in the old days, much of what we did was figuring out how we put patient care into education and research, because that's what we wanted to do at places like Walter Reed, National Naval. You pick a big academic research center, and it was about research and it was about education, and patient care was kind of a nuisance that we had to deal with. And as an administrator, I always found that a little strange, because in medicine, we train by teaching, we teach by seeing patients. It's almost impossible to run good graduate medical education without patients. And the goal of our research really shouldn't be to publish, but to take improvements in care and new technologies to the bedside and into the exam room that really make people's lives better. So what we're on a quest to do here at Walter Reed is to integrate education and research into our patient care activities, because all three have to work together if we are going to advance the science and the knowledge of medicine. And it's not lost on me, and I think particularly autoinflammatory and immune dysregulatory illnesses certainly falls into this category. But there was an article published about 10 years ago, and the estimate was that about 20% of what is done in an exam room between a patient and a provider is based on hard peer-reviewed science. The other 80% is what we would call the art of medicine. It's experience, it's intuition, it's looking for the newest breakthroughs and how to apply them. And I really don't think we've advanced very far in the past 10 years since that article was published. And so today's conference is incredibly important to helping you do that, and coming together between the National Institutes of Health, Walter Reed National Military Medical Center, the Uniformed Services University of Health Sciences, and the constituent groups for this set of diseases, so that we can figure out what is the current state of care, the current state of research, and how we prioritize where we go next. And so I would like to thank you all for taking the time to participate in this today. Thank you again to the team that put this conference on. And I want to invite Commander Reed up now to talk about her and David's experiences, because I think that is a great way to start the day and set the tone for the rest of what you're going to discuss, to remember that at the end of the day, what we're really here to do is to, with great humanity, treat patients like David. So please welcome the Reeds.
Okay. Okay. So welcome to what we hope to be the first annual Autoinflammatory and Immune Dysregulatory Illness Symposium. As many of you know, this is the first of its kind in the U.S. My name is Commander Mari Reed, and this is my son David. We joined this community in June of 2008. It was just a few weeks after Davy's fifth birthday, when his body decided to attack itself. I could go into every detail about the fact that we were on vacation when this happened, that he spent a month in the hospital, that we were in ICU, that nobody seemed to know what was wrong with him or why his body didn't seem to respond to any of the treatments. But rather, I'd like to focus on the outstanding care that he received at Walter Reed and from Dr. Joan and her colleagues. I know in my heart, sorry. Dr. Jones saved his life. But Dr. Jones could not do this on her own. She needed her colleagues, both in clinical and research communities. These patients with the rare diseases don't respond to typical medications, and Davy was no different. To put this into perspective, our older son, who's 5 years older than Davy, had he had the same illness, he wouldn't have made it. The medications that Davy finally responded to had just become available to him. So the treatment and the study and research is vital to this community for these children to have positive outcomes. So as we move forward with this symposium today, please remember Davy's face and the face of all the other children here today. Because of what you do and the expertise that you bring to the table, you will help to make this collaboration to develop a multidisciplinary combined center a reality. Thank you for being here today as a mom, as a military officer, and as a medical provider. I truly cannot thank you enough for your willingness to be here and to move this project forward. We need your expertise, your voice, and your action. Thank you.
Thank you, Commander Reed and Colonel Heimel. I'd now like to introduce up our symposium's planners and directors, Dr. Olake Jones, who's the Division Chief for Pediatric Rheumatology here at Walter Reed, and Dr. Rafaela Golbeck-Manske, who's the Acting Chief for Translational Autoinflammatory Diseases at the National Institute of Allergy and Infectious Diseases.
Well, thank you very much to Walter Reed for hosting the symposium and Colonel Heimel for his remarks and Commander Reed for her introduction. This meeting was put on to actually ignite an autoinflammatory and immune dysregulatory disease referral center network with Walter Reed. And I would like for Dr. Jones to set the stage for some of the background that led to that.
Thank you. It's truly a distinct privilege to stand before you today, this morning, before moms, before our colleagues, our friends. Thank you for everything from the bottom of our hearts, truly, thank you. This is a major accomplishment for one of us, particularly for our patients. We appreciate this occasion. Today, it is an honor to work with Dr. Golbeck-Manske with this endeavor, and we are hoping this will be an annual event, so more to come. But today our focus is how to put NIH and Walter Reed and USIS in the framework of triad objective that was led before us by the leadership. So with MOU that was signed in September 2015, this partnership is equal to using strengths and turning obstacles into opportunities. So the strengths for the DoD includes, we have 9 million beneficiaries under TRICARE, which 2 million of them are children and that equals to 2% of US population, pediatric population. And Walter Reed, under the direction of Colonel Newton, offers full inpatient and outpatient services in pediatrics. In NIH, we have world-renowned expertise, research, and patient care, and many of them are here with us. Thank you. And particularly autoinflammatory and immune dysregulatory illnesses. Obstacles, on the other hand, Walter Reed is the only hospital, military hospital, with full-time pediatric rheumatology service in the entire DoD. And 1 out of every 2 children in the United States under the DoD lives in states with 0 or 1 civilian rheumatologists. At NIH, in my understanding, the care is not allowed for children below 2 years of age, and some pediatric subspecialties are not available. So this is the current model that we have. In military, if there is no military provider available, the local civilian resources are seeked, and there are 3 major TRICARE regions, West, North, and South, and I understand North and South are combining now, so we'll have East and West only. But there are some boundaries for patients to cross these regions. So the proposed model that we are hoping to work out today is for the autoinflammatory and immune dysregulatory patients to be able to provide utmost care, patient-centered care, as well as patient-centered research with our partnership between NIH and Walter Reed. In turn, this will provide feedback mechanisms to the providers through education, telemedicine, and continuing communications.
I'd like to introduce the program. Currently, there are over 350 mutations known to cause immune dysregulatory and autoinflammatory diseases. Since 1997, the discovery of the gene for familial Mediterranean fever, over 20 genes have been identified to cause autoinflammatory diseases. And in the last 8 years, we have 4 approved, FDA-approved drugs for the treatment of autoinflammatory diseases. However, there is much to do, and we will lay out in the symposium the work ahead. The first part of the symposium actually gives a brief overview of the discoveries of the genetic causes of autoinflammatory diseases and some translational efforts that led to the approval of drugs for these conditions. And after the coffee break, we'll talk about resources at both sides of the street and how to best pool them to make this a viable effort. And in the roundtable discussions, we will start developing SOPs that help us, or actually discuss SOPs that help us work together and have a clinic on the Walter Reed, a joint clinic, autoinflammatory disease clinic on Walter Reed grounds. We'll discuss resource sharing and then also explore the role of the immune dysregulatory pathways that are identified to cause autoinflammatory diseases in causing conditions of military relevance, such as sepsis, vaccine reactions, and impaired wound healing. So I hope you will all stay for the roundtable discussions for brainstorming on those issues, and thank you again for being here today.
Thank you, Dr. Jones and Dr. Golbach-Mansky. Next, I'll invite Ms. Erin Wilson and Ms. Karen Durant, representing the needs of the community and the Autoinflammatory Alliance.
Good morning. Thank you for coming, and the fact that many of you have traveled long distances serves to remind us just how important this is. I'm Erin Wilson. I'm an Air Force wife, and a mom to 4 beautiful daughters. We're stationed at Offutt Air Force Base in Nebraska, home of the 55th Wing and National Airborne Operations Center. I'm here on behalf of our military families battling every day with a rare disease. This is my daughter, Kathleen. Kathleen's 12 years old and is diagnosed with a hyperimmunoglobulin D, which is a disease that less than 300 in the world have. As you look at her, you couldn't tell that since birth she would have symptoms of fever, headaches, vomiting, stomach pain, rashes, mouth sores, and joint pain every 2 weeks like clockwork. That's because through the many dedicated subspecialty doctors here at Walter Reed and NIH, she is on a biological drug that enables her to be the bright, fun-loving girl that she is. We struggled for 9 years before this would happen because of lack of research. There's over 60 military families that I'm aware of that have a rare autoinflammatory disorder. That doesn't sound like a lot, does it? But considering it takes 1 in 1 million to have a rare gene, it is significant. We're battling in our own war. Just like our troops on the front lines that wouldn't leave anyone on the battlefield, on the home front, we shouldn't either. But sadly, many children are left untreated and undiagnosed. More research is needed because these diseases are lifelong. We need care and support of the unique doctors who report to duty, ready to rise to the challenge of treating the unknown. It's difficult to have this new job of caring for a rare child. Throw that into the mix of being a military spouse, where we are subject to deployments, PCSing often, shift work, alert schedules, changing doctors, and educating them at the new base. Do you want to know what the day of a life of a military parent is with a rare disease? It's going to bed late, it's rising early, if we even went to bed. We're cleaning up wet bedding or vomit in the middle of the night. It's the long wait on hold to make a doctor's visit in the morning, because now we have 106-degree fever and a rash, and the list of symptoms will go on as the day does. We go to the appointment and we see a doctor who's unfamiliar with this, and even though we've been at the clinic before, they shy away from treating us. We parents are researching, we're Googling, all while maintaining this household. For the few that are being treated, we may have to give an injection that burns as it goes in, and our child is screaming and kicking and fighting with all that she has. And sometimes we have to do this because our spouse is deployed. Then it's another battle at school. We're teaching the teachers that the fever and other symptoms are not contagious. Our children are very bright, but the test score may not reflect that. And we're often told that they look fine. And being untreated and undiagnosed, many are absent from school. It's exhausting to hear that TRICARE has denied the genetic test or the medicine that could help treat us, and it leaves us baffled and angered that research has proven it would greatly help our kids. Having a child with a rare disease, it's not seeing just one doctor. We need multidisciplinary care. We need continuity of care. We need research. We need Walter Reed, and we need this collaboration. Pediatric rheumatologists are few, and some are not up to date on the new research in medicines. Some areas it takes months to get the rheumatologist appointment, and oftentimes we leave without a solid treatment plan. Early diagnosis is vital. If all families are granted the opportunity to visit Walter Reed, the data that will be gathered can be used to learn more about these disorders and help our civilian families. Recently, I was asked, what does it mean to go to Walter Reed? In one word, it's priceless. It's a family. At Walter Reed, everyone has their own story and struggle, but it's a feeling of camaraderie, that we are military strong. And it's where the military takes care of their own. The ability for us to come here is the best benefit the military has given us. But that's not the case for these 60 families. Many cannot get here to Walter Reed. Many don't have the care at the local children's hospital that is here. So my question to you is, what can we do about that? 60 of our own little warriors need your help. I will end with a quote from St. Mother Teresa. I alone cannot change the world, but I can cast a stone across the waters to create many ripples. It's my honor to introduce to you Erin Durant, founder of the Autoinflammatory Alliance.
Thank you. Hi. Thank you, Erin. Those were very powerful and touching words and deep to my heart, because I also, my name is Erin Durant, and I am a pediatric nurse, but also mother of 3 boys, and one of them happens to have a rare autoinflammatory disease called Nomad syndrome, which is the more systemic and severe form of cryopyrin-associated periodic syndromes. And so it's a very great honor to be a part of the symposium. That's something we've dreamed and wanted and hoped for a very long time, to see this collaboration between the National Institutes of Health and Walter Reed National Military Medical Center to better address the needs for autoinflammation and immune dysregulation and the needs of patients, not only in the military, but others in the US and worldwide. I have a slide here. This only shows we have over 3,500 patients that we help in our organization. This is voluntarily pinned by patients. This only shows about 10% of where they are, but the idea is that there are lots of them, more than this, and all around the world. And if you see that little pin between Iceland and Norway, that's not a mistake. There are a couple of patients on the Faroe Islands even. So it's, it's amazing how we've been able to bring people together. And this, we've been coming to the NIH for my son's medical care since 2003. And before that, we struggled for a few years trying to get him a diagnosis. Major serious bad things happened. We had some significant things that could have taken his life. And coming to the NIH has changed his world. Clinical trials that put him on a medication that gave him a much better future. And that's one thing with these diseases. They're rare diseases, but there's hope with a lot of them. There are medical treatments that can help or are being discovered, but getting them diagnosed and treated early and properly can change everything and make a big difference. And so our experiences of us trying to deal with getting our son diagnosed and meeting other patients and in some online communities and in person at NIH, and realizing our journey and experiences were not the exception, but the norm, that everyone was having these challenges are much worse than us, and that people didn't know how to navigate, how to deal with finding these information. So we decided to start an organization to help improve awareness, care, and treatment for these diseases, and to empower, inform, and advocate for patients with these conditions. This is a slide Erin had a really great explanation of what goes through for patients. And we did a study on our CAPS patients in 2013 to 2014 to get to better understand the challenges we chose this one disease to do the study, but we would like to get more information for all of them. But this would show that how far patients are going and trying to see an expert, because there are very few specialists. And we live on the West Coast, which we've discovered that it's especially difficult to find people west of the Mississippi, and our patients are traveling long distances and trying to get somebody. So we really hope to see a national center for autoinflammation and immunodysregulatory diseases started. And I think that this is the right place and the right time to have that happen between Walter Reed and the NIH. And I won't go through all these things. We can discuss this more later, but this is some things that we feel that we can hope to see and how it can make a big impact, because, let me change the slide. Because patients Erin had explained, there's some common challenges that with issues to access the specialist, denial of genetic testing, or insurance denials calling it investigational only and not necessary, and extreme delays in diagnosis, and also some problems with doctors that may be making a diagnosis but then tell a patient, but I don't know how to treat it, I don't feel comfortable treating this, so you need to find somebody else that will. And this happens way too often, and it's rather surprising. And for example, this is some examples from military families from a survey we did on them to find out their issues. Whoops. Anyways, so the slide's there to go with it. One patient happened to have a lifelong history of fevers, inflammation, hearing loss, dental issues, and many other complaints. And then they have a child with similar issues that was born, which those combination of symptoms happen to fit with a few of the autoinflammatory diseases, especially CAPS, which my son has one of them. But this family was denied genetics by TRICARE many times, even though their symptoms would have gotten them an immediate referral and coverage for these conditions in some other circumstances, and it has greatly delayed their diagnosis and their suffering. And some other problems, and these problems, this is a common problem not just in the military system. This is one big problem that we hear all the time, and we deal with patients trying to help them. People are even paying out of pocket thousands of dollars to get genetic testing. But also, sometimes even if they get a diagnosis and have a disease that has FDA approved drug for it, which is not that many of them, including, we have a story from a family with SJA, systemic juvenile idiopathic arthritis, that as Commander Reed had explained, without the right treatment, a patient will die. And because life-threatening complications can happen, such as macrophage activation syndrome. And delaying treatment can put the patients at risk. And some of these patients have actually been denied the biologics and medications, and they had to be delayed on getting approval. And thankfully, they did get it eventually, and they're doing better. But these are scenarios that should not be happening, especially with drugs that are available. And as you can see, this is a challenge for our patients trying to find a doctor to help them. And the 19 plus at the bottom, almost 20% of the patients have trouble having to, and they've seen that many doctors, and to get a final diagnosis, which is a victory for them. And let's see, oops, trying to change the slide. Anyway, so we really appreciate this opportunity and feel that the collaboration between the centers is going to make a big difference. And that one big thing that we'd like to see is training and helping other doctors outside, because it's hard to expect you all here to do everything for the growing numbers of patients in the US and worldwide that need your help for these diseases. But if you can train and collaborate with outside specialists, it can make a big difference. And early diagnosis and treatment can save lives, and the quality of life for patients is greatly improved. That can make a big impact on their future. My son that has NOMID has a much different outlook and opportunity. His disease, 1 out of 5 children used to die before adulthood. And he's turning 17 this week, hoping to get to go to college, doing well in school despite some serious challenges he's had. And in just like Erin's daughter, when you look at them, you wouldn't say he has something right off. You know, which is the other challenge with these patients, because when you treat them, there's still stuff going on, but it might not be as obvious, but it still needs to be managed by experts. So I really appreciate this, and thank you so much.